biologijos, medicinos ir geomokslų skyriaus posėdį skirtą aktualiems imunologijos klausimams. Labai džiugu, kad šiame renginyje turime garbingą užsienio svečią, ilgametį mūsų užsienio narį ir išklausysime jos paskaitos. Dear Professor Hartmut Peter, it is a very big pleasure to have you here and to listen your lecture about immunoglobulin G related disorders. But first of all, I would like to give the word for opening our meeting for Vice President of our Academy of Sciences, academic Zenonas Dapkevičius.
Okay, this meeting maybe will be in two languages, English and Lithuanian. First I will try to say a few words in English language. Very nice, professors, that you came here because we have in Lithuania 62 foreign members, but not big communication with them. And the very good tradition started biology, medicine, and geoscience department, and they started to invite foreign professors, foreign academics, foreign members of our academy to present their job, work, and very good tradition. Maybe this tradition will use in future on other departments. And today very important topic is immunology, and for me it's a little bit difficult to understand this research, but some knowledge I know because I'm plant pathologist. And plant pathologist, immunology is very important for plant science, for animal science, as well as human science. And today will be nice to listen to your lecture. And I found in books a lot of synonyms of immunity. Immunity, resistance, strength, fastness, hardness, inviolability, sensitivity, and maybe more. Is it the same or not the same? Difficult to say. Yeah. Tai tiek norėjau pasakyti angliškai, bet lietuviškai irgi imunitetas. Aš čia noriu pasakyti, kad Tamošiūno paskaičiau visuotinį lietuviško enciklopediją, kas yra imunologija. Tai yra imuno daugtašis plus graikiškai logos mokslas. O kas yra imuno lietuviškai, tai nėra labai tiksliai išaiškita. Tai irgi lietuviški pavadinimai yra imunitetas, atsparumas, neliečiamybė, atleidimas, neliečiamumas, neimlumas. Ar tinka visi tie terminai ar netinka, tai irgi reikia diskutuoti. Tai tie gal keletą žodžių, džiugu man būti kartu su jumis ir bus keletą kitų paskaitų. Tai good lectures for you and good communication.
Taip, dėkojame viceprezidentui. And now I would like to ask the long-standing member of Lithuanian Immunology Society, Associate Professor Stasys Gentvilis, to tell several words about collaboration with Professor Hartmut Peter, because this collaboration lasts for many years, starting from the period of Second Lithuanian Independence. Taigi, paprašysime, gal lietuviškai bus paprasčiau.
Ačiū labai už suteiktą žodį, didžiai gerbiami viceprezidentą, gamtos, medicinos ir geologijos mokslų skyriaus pirmininkė Kupčinskai, gerbiami akademikai. Man dalyvauti jūsų tarpe didelė garbė ir malonumas ir jo labiau, kad leista pasisakyti. Aš su dideliu malonumu ir noriu pristatyti šiandien mūsų svečią akademiką, jūsų akademiką Hans Hartmut Peter, su kuriuo mus sieja jau labai daugiametė draugystė. Kiek prisimenu, pirmiausiai jis atvykdavo pas mus į Lietuvą dar vadinamai sovietiniais laikais. Buvo, prisimenu, vienas iš pirmųjų kartų, kai akademiko Vlado Lašo buvo jubiliejus ir tada buvo organizuojamas konferencijos alergijos klausimais. Taigi, nuo tada pradėjau lankytis beveik visuose mūsų alergologų konferencijose, bet labiausia mus turbūt su Lietuva suartino ir kas padarė dideliu mylėtoju Hans Hartmut Peter, tai mokyklos, kurias vokiečių imunologai padedant ir vadovaujant profesoriui Peteriui ir Šmitui, jo draugui imunologui, 6 metus iš eilės, pradedant 93 metais, buvo organizuojamos imunologų mokyklos, kurias atvykdavo apie 15-20 lektorių imunologų, garsių imunologų visoje Europoje, ne tik Vokietijoje, bet ir visoje Europoje. Iš Švedijos būdavo, iš Šveicarijos, iš Prancūzijos ir kitų. Netgi vienas, prisimenu, pirmąją mokyklą, kur dalyvavo Nobelio premijos laureatas Kioleris. Taip kad tų laikų kolegos, kurie dalyvaudavo, ponia Aurelija, akademika dabar ir taip toliau gerai prisimena tas mūsų mokyklas. Ta, žinoma, labai suartino profesorių su Lietuva ir su jo žmonėmis ir bebendraujant atsirado galimybė ir nemažai mūsų žmonių išvykdavo į Vokietiją pas profesorių Peterį į kliniką, kad įsisavinti imunologijos tyrimų metodus, dalyvauti bendruose tyrimuose ir panašiai. Dalis jų grįžo, dalis, žinoma, negrįžo, kad tik įsisavino tyrimų metodus. Ir panašiai, kiti buvo ilgalaikėse, netgi stažuotėse pas jį. Tas labai suartinimus atsirado galimybė ir ne tik tai keistis mokslininkais, bet ir publikuoti darbus ir panašiai. Beje, ir lėšas pritraukdavo tuo metu mokyklų organizavimui profesorius Peteris su savo kolegomis ir vėliau buvo netgi pritrauktas didelės industrinės įmonės kaip Volkswagenas ir panašiai, tam, kad būtų galimybė tas mokyklas organizuoti. Kai tik tai profesorius Hartmutas buvo mūsų numatyta kelionė šiais metais į Lietuvą, kadangi anksčiau čia porą metų dėl koronos epidemijos negalėjom, tai jis pirmiausia sako, aš noriu susitikti akademijoje su kolegomis ir perskaityti paskaitą, parodyti, kad bendravimas tikras, nuoširdus turi vykti ir mokslo, kultūros srityje pirmiausia, o galbūt, kad visi žmonės suprastų, kad tai yra tikrasis žmoniškasis bendravimas, o ne toks, kaip dabar vyksta Ukrainoje, karas, kas žmonės išskiria, o nesuartina. Taigi dar kartą ačiū už pakvietimą, už priėmimą mūsų profesoriaus ir geros sėkmės.
Thank you for Associate Professor Gendvilis for his story about long-standing collaboration between Lithuania and Germany in immunology area, initiator of which was Professor Peter. And now I would like to ask Professor Aurelija Žvirblienė, the president of Immunology Society, the partners of today our meeting, to say a little words for beginning of our meeting and lecture.
Thank you. It's really a great pleasure to welcome Professor Peter in Lithuania. And I would like just to show several pictures which illustrate information already provided by Professor Gendvilis and illustrating the events which were organized together with German Society for Immunology. And I also would like to remind that Professor Peter is not only foreign member of the Lithuanian Academy of Sciences, but he also is the honorary member of Lithuanian Society for Immunology. And so, together with German immunologists, our society was organizing many meetings, and we are really very grateful to German immunologists and especially Professor Peter for organizing these first immunology schools. And I also was participating in that time as a young immunologist, and many members of our society, so they have participated in these international schools. And here they are listed, these schools starting from 1992, Palanga, Trakai, Nida, and here is the picture, I guess, from Tartu, from 2001, because Raivo Uibo is in the center, and he was in that time the president of the Estonian Society for Immunology. And here are some pictures from conferences and schools organized together with the German Society for Immunology. And here is the conference organized in 2005 on innate and adaptive immunity. And here also another prominent German immunologist, Reinhold Schmidt, who also contributed a lot to our collaboration, and he unfortunately passed away last year. Here are some pictures from the Academy of Sciences when Professor Peter was appointed as a foreign member of the Academy of Sciences. It was in 1999, and here is with the president of Lithuanian Society for Immunology, Professor Vitas Tamošiūnas. Again, this is 1991. And here's some more pictures, and I'm sorry, I don't know exactly what years are of these pictures, but you look the same. You look the same. So, but yes, but it was at least 20 or more years ago. So I guess it was from this conference organized in 2005, because not in every school you had made the presentations, but it was the case. And here are two old friends. So this is probably again from 1999. And here is the last picture. So it was just reminding how it was many years ago. And now we are really happy to welcome you again in Lithuania and listen to your presentation. Okay. So if you would like to show, here is, yes, now I. Or maybe, yes, we will change this. And if you would like to show, here is the laser pointer, and just And the slides are changed here. Okay. I don't know which one is better for you, this one or this one? Because only one is working
Only one
in
is
the
working.
same time, yes.
So I prefer this one.
Yes, then
That is
maybe
working.
you prefer to see. Yes. Maybe we have just to exchange the seats. Okay. Please sit here, maybe it's better.
No, it's this. Okay, all things. Okay.
So I'm very glad to be here. Thank you for having me here. And it's a great pleasure to meet many old friends. And I don't know how often we can still do this, but I was very glad to have a chance again to come to Lithuania. I'm a rheumatologist and clinical immunologist, and I decided to present a rather new disease. And to be honest, I didn't believe that we would actually assist during my lifetime to many new diseases of immunology. But this is a disease which is actually 20 years old. It was first described in my conflicts of interest. It was first described in 2003 by a Japanese researcher, Kamisawa, and it's characterized by a fibro-inflammatory systemic disease which presents initially as afebrile, solid, tuberous tissue induration. In biopsies of affected organs, high proportions of IgG4 positive plasma cells, in fact more than 40% of the IgG positive plasma cells are found to be IgG positive, IgG4 positive. Also, the majority of the patients have an elevated serum IgG4 concentration, above 1.4 gram per liter. And often multiple organ regions can be simultaneously affected. The phenotype and epidemiology of the disease is as follows. Organs and tissues may be affected, such as lacrimal glands, salivary glands, pancreas, thyroid, lungs, liver, ductus hepaticus and pancreaticus, gastrointestinal tract, kidneys, prostate, retroperitoneum, orbita, lymph nodes, and meninges. So it really is a systemic disease, or can be a systemic disease. Not all these organs have to be affected, but once you have discovered the disease in one organ, you better look for others. Systemic symptoms are rather rare, particularly if there's no fever. And as you will see later on, fever would be an exclusion criterion for this disease. Swelling and damage of organs by pro-inflammatory infiltrates prevail. There's a slight male dominance in Japan, where the disease has been first described, and in South Korea. The incidence is about 2.6 to 10.2 new cases per million inhabitants and year. Peak incidence in Japan is the 6th and 7th decade. Now, as soon as this IgG4 related disease was defined or came up, several other previous disease entities fell into this spectrum, like Mikulicz syndrome, infiltrate of lacrimal and or salivary glands, Kidney's tumor, infiltrate of submandibular gland, Riedel's thyroiditis or the iron heart struma, eosinophil angiocentric fibrosis of orbita and upper respiratory tract, multifocal fibrosclerosis, inflammatory pseudotumor of orbita, lungs, kidney, and other organs, the mediastinal and retroperitoneal fibrosis, known as morbus Ormond, periaortitis, inflammatory aortic aneurysma and periaortitis, and last not least, an idiopathic hypercomplementemic interstitial tubular nephritis with intense tubulo-interstitial immune complex depositions, mainly composed of IgG4. Now, here are some of the clinical manifestations of the disease. I thank Emma Calder from Oxford for kindly offering me this collection. You can see this is submandibular swelling, orbiter infiltrates in the left orbiter, and this is a massive thyroiditis, very dense and hard. And then you have, of course, pulmonary infiltrates, pleural tumors, and you have retroperitoneal masses which eventually will compress the ureter so that you have a kidney problem with this mass. And it took almost 2 years to come up with a huge consortium of scientists in America and in Europe to make a classification or to establish classification criteria for IgG4-related disease. It's a three-stage classification process. The initial signal criteria are 1 out of 11, characteristic clinical or radiological involvement of typical organs, pancreas, salivary glands, bile ducts, orbit, kidney, lung, retroperitoneum, and thyroid gland, or pathological evidence of inflammation in these organs accompanied by polyclonal lymphoplasmacytic infiltrate of uncertain etiology in one of these organs. I'd like to stress that the disease is polyclonal, it's not a monoclonal disease. You have up to 32 exclusion criteria. That is, if one of these criteria fits to your patient, he doesn't have IgG4-related disease. The most important is fever. The patients usually don't have fever. Then you have a number of 8 inclusion criteria which are weighted in the sense that you get up to 8 points or 16 points if we have bilateral involvement. And this weighted criteria applies to histopathology, immunostaining, serum IgG concentration, bilateral lacrimal or parotid, sublingual and submandibular gland involvement, chest involvement with peribronchial thickening, pancreas, biliary tree, kidney hypercomplementemia in the nephritis, interstitial nephritis, and you have renal pelvis thickening in the retroperitoneum. Now, there have been 2 cohorts of patients included, one cohort in the United States and one in Europe, and it came out that the total inclusion point number above 20 and no exclusion point was in these 2 cohorts very effective. So with a specificity of 99 to 97.8% and a sensitivity of 85.5 and 82% respectively, the diagnosis could be actually established. This is a very strong argument that this disease exists independent of the country where it is discovered, or also independent of the physicians. Now, I'd like to come now to a more theoretical point, which is designed to give you an understanding how IgG4 actually, what are the peculiarities of this subclass, and how it actually is involved in the pathophysiology of the disease. Now, first, let us have a look in the serum, where the immunoglobulins, which run in the gamma fraction, are listed here, and you have IgG4. This is the lowest concentration of the IgGs is IgG4. Actually, to an extent that it took many years until a reliable measurement could be actually established for this disease, for this subclass. What is known about the clinical relevance of IgG4? Now, it plays a role in allergic immune reactions, so-called type 1 reactions of Coombs and Gell, and in the defense against parasites. Serum IgE and IgG4 show an increase in parasitic diseases, such as schistosomiasis, and in chronic allergic stimulation. There's the famous beekeeper's paradox. That is, somebody who keeps bees to actually collect honey, he will be stung by bees many often. And only in the beginning, he shows strong reactions. Over time, this reaction disappears, no longer any symptoms. And actually, the reason is that they develop mainly IgG4 antibodies, which protects them against inflammation. And IgG4 protects mast cells against degranulation via modulating cell activation. I'll show you this in a minute. And a combined IgG2 and IgG4 subclass deficiency is long known and is associated with increased respiratory tract infection and a selective antibody deficiency. We'll say that you may still have normal total IgG in your serum measurement, but if the two subclasses, which both are not very important in concentration, if they actually are low, you have specific antibody deficiency against certain bacteria or viruses or what have you. Now, the existence of a selective IgG4 deficiency is debated. If it does exist, it seems to favor an increased susceptibility to respiratory tract infections. Now, let us have a look at the properties of IgG subclasses. You know that we have IgG1, 2, 3, and 4. All have a molecular weight around 150,000. The mean serum concentrations are different. The most abundant is IgG1, and the least abundant is IgG4 with a mean concentration of 0.5 milligram per milliliter. They're different in their heavy chain composition. That means they have certain amino acid differences in the heavy chain. The half-life is more or less the same, except for IgG3, which is only 8 days, and otherwise it's 23 days. And now come the functional aspects. The classical complement activation through the Fc portion of immunoglobulin G is not actually functioning as IgG4. It does not activate complement. It does bind to a certain extent to the high affinity Fc receptors on macrophages and dendritic cells, but not as well as IgG1 or IgG3. And it does bind preferentially to an Fc receptor which is called Fc gamma receptor 2b or CD32b. And this is one which actually induces inhibition of inflammation in macrophages and dendritic cells. And then is a unique property of this IgG4. This is the Fab-arm exchange. I'll show you in a minute what this means. Let us have a look at the biochemical properties of IgG4. You have here the light chains and the heavy chains, and you have the antigen binding area of the combined heavy light chain. And in the Hims region, there are two SS bridges, and in the IgG4 you have a serine in position 228, and under reducing conditions, this allows that the S bridges are cleaved, such that the molecules fall apart. Then you have in position 234 phenylalanine, which actually reduces binding to Fc gamma receptors, 2A and 3A, which are activating receptors. Sialic acid in position 297 promotes binding to inhibitory Fc receptor 2B, the CD32 molecule. And finally, you have proline position 339, which abrogates C1q binding and activation of classical complement pathway. So these together give to this molecule a very peculiar set of functional peculiarities. Here's the Fab-arm exchange, which is only observed in IgG4. Normally, an immunoglobulin G is bivalent and monospecific. That means it does have two binding sites for the antigen. If the molecule falls apart here in the middle and reassociates with another half part of immunoglobulin, you wind up with a monovalent binding in one part of the IgG and a B-specificity. Now, approximately 50% of the IgG4 molecules in the serum have this form because the free Fab arms reassociate freely with another one. And that, of course, is not very advantageous for antigen complexing, for immune complex formation, and thus immune complexes of this type are less pro-inflammatory for macrophages and dendritic cells. Now, we have to have a look on the peculiarities of Fc gamma receptors, which bind IgG1 to IgG4. And there are two types of gamma receptors. A high affinity one, which is CD64, and it is more or less restricted for IgG1, expressed on macrophages, polymorphonuclear cells, eosinophils, and these have an ITAM motif intracellularly, which activates the cells. Then you have 4 low affinity receptors. Most of them have an activating ITAM motif, and except CD32B, this famous inhibitory receptor, which has an inhibitory motif in this intercellular part, and which inhibits B cells, dendritic cells, and macrophages, and makes them less inflammatory. Now, Taco Kubus from Holland actually has proposed a model where he opposes IgG4 to IgG1 on a balance. This is anti-inflammatory, and this is pro-inflammatory. Binds activating complement receptor, Fc gamma receptors, activates complement, and does not undergo Fab-arm exchange. And the IgG4 does not activate complement, binds to inhibitory Fc gamma receptors, and undergoes Fab-arm exchange. So in a way, you have less inflammatory consequences from an IgG4 molecule than from the IgG1. If your immune system makes mainly IgG1 antibodies, you are risking to have a high inflammatory potential, for instance, in the airways. If it makes only IgG4, it doesn't. So this is a kind of a rescue mechanism in the immune system against too much Fc-mediated activation of immunoglobulin Gs. Now, IgG4 antibodies can block IgE-mediated allergic reactions. Those of you who are working in allergy, and there's quite a few in Lithuania, know that during B-cell class switch, IL-10 and IL-13 promote switching to IgG and IgE. This is a classical Th2 response. Repeated desensitization, as in the beekeeper model, with allergen leads to a modified Th2 response during which IL-10, in the presence of IL-4, drives class switching to IgG4 without IgE production. And finally, mast cells express an Fc receptor for epsilon, for IgE, and one for Fc gamma receptor 2b, the inhibitory one, which can bind IgG4. And in a model, it looks like this. This is from Straight and Morris, Fingelmann's group. Here you have the mast cell full of granules with pro-inflammatory material, and the IgE is already bound, and the allergen comes, and it leads to a degranulation and release of granules, sneezing, bronchospasm, and so on. Now, if at the same time you have an IgG4 molecule binding to the Fc gamma B receptor, and if this molecule is specific for the same antigen as that is bound to IgE, then no degranulation takes place. It's probably the mechanism by which desensitization against pollen, house dust actually works. It's production of more IgG4 that can inhibit the mast cell degranulation. Now, IgG4 may also play a deleterious role in cancer. And that goes back to a paper I happened accidentally to be part of the authors in 1977, when Marianne Davot in Paris asked us to give a serum for melanoma patients because she wanted to study IgG4 concentration in this serum. And she came up with a staging, like stage 1 melanoma has only 2% of IgG4 elevated, stage 2, 31, and stage 3, or disseminated, more than 40%. So it's actually in melanoma patients high or elevated IgG4 concentrations are indicative of dissemination. At the time, we could not actually explain what that meant. It was unclear. We thought that IgG4 perhaps contains facilitating antibodies for tumor growth, but it was not really clear. Now, Karagiannis came up with a very nice study in 2013, and he kind of detailed this observation. Particularly in melanoma, cutaneous melanoma, he could find that the skin around the melanoma cells contains many IgG4 producing plasma cells. And they actually favor the growth of the tumor. And he made a ratio of IgG4 to total IgG, and if that is above 0.4, 0.04, then the prognosis is good. If it's below, it's bad. You had here, cutaneous melanoma has quite a lot of IgG4 positive plasma cells. And in the serum, you have subclass elevation, as we showed it already in 77. Now, come to the pathology of this IgG4-related disease. And there's a paper from Stone in 2012, where he actually could differentiate the infiltrating lymphocytes. So he found Th1 and Th2 cells. He found cells that produce interleukin-5, which is responsible for an accumulation and attraction of eosinophils. You always find eosinophils in these infiltrates. Mind you that IgG4 and IgE have to do with parasite control, and that involves also eosinophils. Then you have interleukin-13 and interleukin-4, and that actually drives cells to IgE production and to IgG4 production. And there is particularly important interleukin-10 and interferon gamma, which is produced by a subtype of CD4 cells. They can kill at the same time, but they produce these two cytokines, which actually then favor class switch to IgG4. And last not least, TGF-beta, a cytokine which is instrumental in promoting fibrosis, and this is very strongly expressed in these infiltrates. What drives the IgG4 immune response? I think it could be persistent antigen, like parasites, but in these biopsies which we took from the patient, there is no parasite. Then repeated antigenic exposure, the beekeeper paradox, or autoantigens. Now, interestingly, and I'll show you this in a moment, mRNA vaccines tend also to favor IgG4 responses. This is a very new paper, and then we have increased production of IL-10, TGF-beta from Treg and Treg cells, induced Treg favor via a glucocorticoid-induced tumor necrosis factor-related protein, class switch to IgG4. TGF-beta enhances tissue fibrosis, and this peculiar CD4 T cell, which is also killing in these lesions, produces IL-1 beta, TGF-beta 1, and interferon gamma. Now, the histopathological landmarks of IgG4-related disease is dense lymphoplasmacellular infiltrate with over 40% of IgG4 plasma cells, as percent of all plasma cells. Then they have a storiform fibrosis, I'll show you this in a moment, obliterating phlebitis, and further findings are non-obliterating phlebitis, increased infiltration of eosinophils, and you can see this here in some pictures. This is the hematoxylin color, dense infiltration of lymphocytes and plasma cells. And here is in the dacranitis or ceranthonitis, staining with anti-IgG and anti-IgG4. And you see a very intense brown staining of cells that is typical for the IgG4 plasma cells. And the majority of the plasma cells are here IgG4 positive. And this is the storiform fibrosis. We call this verwirbelte fibrose. Apparently the pathologists find this more or less typical. And then we have this obliterating phlebitis in these tissues, and also infiltration of eosinophils. Now, Umehara published in 2011 a first set of diagnostic criteria for IgG4-related disease, well before the EULA and American Association of Rheumatologists defined the disease as I showed previously. So the clinical presentation with diffuse or localized tumoral swelling of single or multiple organs, elevated serum IgG4 concentration, typical histopathology, intense lymphoplasma cellular organ infiltration, storiform fibrosis, marked IgG4 positive plasma cells. They either decided to have more than 40% of plasma cells carrying the IgG4 marker, or more than 10 plasma cells with IgG4 marker per high-power microscope field. Now I come to the very recent observation. This is not only by the German group of a consortium from several microbiology departments in Germany, Irrgang, Gerling, Kocher, and al. They described that class switch towards non-inflammatory spike-specific IgG4 antibodies after repeated SARS-CoV-2 mRNA vaccination. And it came out that after the first vaccination, only 0.04% showed IgG4 antibodies, whereas after the second, almost 20% were IgG4 positive. Now, this same observation was not observed after vaccination with adenoviral vectors. So, of course, speculation goes on whether breakthrough infections in vaccinated people might partly be due to this high concentration of IgG4 antibodies. This is a paper which is highly cited in Science, and some of the results, you can see them, IgG1 after the second and third vaccination and the follow-up periods, they rather tend to go slightly down, whereas IgG4 goes up, particularly after the third vaccination. And IgG3 and IgG2 behave indifferently. And here you have the proportion of IgG4 positive cells after the third vaccination. Almost 20%, versus 0.04% to begin. Now, the take-home message is if you have unclear tissue or organ swelling, lymph node enlargement, and inflammatory tissue fibrosis, you should actually think of IgG4-related disease in the differential diagnosis. It's not monoclonal, it's polyclonal. It's a rare but important differential diagnosis to infections, malignancies, and traumatic diseases, and it may affect more than one organ. Immunosuppressive therapy is effective, but recurrences are frequent. The risk of malignant transformation over time seems to be increased. Now, treatment options, this is my last slide, for this IgG4-related disease. Not all cases require an immunosuppressive treatment. However, prolonged inflammatory activity increases the risk of organ fibrosis. Early phases of IgG4-related disease respond usually well to glucocorticosteroids. There is no validated recommendation of steroid dosing and tapering. Usually a weight-adapted starting doses of 0.6 to 0.8 milligram per kilogram body weight prednisolone per day, with a gradual reduction to finally 5 to 10 milligram per day over 4 to 6 months, is adopted by most centers. Data from Japan show that the majority of the IgG4-related disease patients require a continuous daily dose of 5 to 10 milligram prednisolone. And steroid-sparing immunosuppressants such as azathioprine, methotrexate, cyclosporine may be tried, even cyclophosphamide can be an option in refractory cases. And finally, recently successful use of rituximab has been reported in some cases. And with that, I'd like to thank you for your attention. I'd be glad to answer questions.
Thank you very much for Professor Peter for very comprehensive lecture on disease which is currently in Lithuania is well known, and I think in many specialties doctors diagnose it, particularly in gastroenterology. We have enough cases of immunoglobulin G related pancreatitis, immunoglobulin G related cholangitis, and so here also are both immunologists basic, both clinical, and I hope that several questions could be held. Professor Aurelia, please.
Thank you very much for this interesting presentation, and especially about mRNA vaccines. It's really interesting data. And as I know, in clinical trials, nobody looks for IgG4. Usually IgG1, IgG2A, but nobody looks for IgG4. And that's why only scientists can discover some consequences, because not the vaccine producer is interested in that. And also I have a short question. What is your opinion about the detection of antigen-specific IgG4 in clinical labs? Because it's quite usual when some labs are just measuring let's say, food antigen-specific IgG4 and drawing some conclusions from that. So what is your opinion about that? Thank you.
So I don't have a own experience with IgG4 allergic antibodies against food allergens. But I know from the people who did this study on the mRNA vaccine response, they actually measure, they put the antigen in a plate, put on IgGs or serum, wash it, and then stain with anti-IgG4. And that seems to be a simple and reliable method. But I agree that previously nobody was really looking at IgG4. It was, one knew that it has to do with allergy and may have to do with parasitic defense, but it was not really measured in the context of possible immunodysregulation, as we see it here now.
Thank you. Please, Professor Malinauskienė.
Thank you very much for your lecture. And I would have a pure clinical question. So if you, so many people were vaccinated using mRNA vaccines, so what would be your prognosis? Maybe in the nearest future we can have an outbreak of IgG4 related diseases, or this response also wanes as...
That's a very good question. And, this has been asked by many very intelligent people. And I think what shows the reality is that we have breakthrough infections to COVID, but they are not very serious clinically. And once, and this may be individually dependent, your IgG4 response predominates, you may be more likely to have a recurrence of the disease. But still, I think you do also have IgG1 antibodies which serve valve for protecting you. It's interesting that our STIKO, the German Commission for Vaccination Recommendations, do not recommend more than 4 vaccinations in a row, because they're aware of this phenomenon now. I can't say how this is actually going to work in next year, if you have a booster reaction together with influenza viruses, but we are to watch out.
Yes, thank you. I also have some continuation of this question. In my clinical practice, I really notice that immunoglobulin G4 now we can see more often, and it is related with vaccination, and it could be cause some difficulties for diagnosing of immunoglobulin G related diseases, because of course we have also cases of asymptomatic elevation in immunoglobulin G, or it's, for example, pancreatitis. In case of vaccinated person 2 or 3 times, it could be related with immunoglobulin G, or it is simple elevation due to 3 times vaccination. Of course, it's unclear again what is the long-term consequences of immunoglobulin G elevated in these asymptomatic persons. So what is your opinion on that?
My opinion is that we have to stay curious about these developments. And as you mentioned, this pancreatitis against this pancreatitis type 1,
yes.
Which is IgG4 related. And one of my first patients I encountered, without knowing that actually this is a disease he had a mass in the pancreas, and he was operated for pancreas carcinoma. And then the surgeon called me during the operation and said he had never seen a picture like this. He should come and have a look at it. And it was stone hard, the tail of the pancreas. He took it out. Now the patient had also lacrimal gland swelling, parotid gland swelling, and he took it out, and the next week the lacrimal swelling decreased, but only about 2-3 weeks, and then it came back again. So it kind of was connected, this disease. We had at the time not measured IgG4. The patient is still in our outpatient clinic, and of course he has high IgG4 levels. But I can't actually answer your question. If we have high IgG4 levels after, let's say, 4 or 5 corona vaccinations, does this do anything to pancreatitis?
So we maybe only surveillance of such cases, long-term surveillance could answer the questions about long-term consequences.
Yes.
So thank you. Maybe any other questions? So we will have some discussion with coffee after all our meeting. In this case, I would like to invite the second our lecturer, Professor Laura Malinauskienė, and she will deliver a lecture, Immunodeficiency Conditions in Lithuania, Clinical Practice and Challenges. Please.
Dear Professor Peter, dear distinguished academicians, dear colleagues, I am a doctor, physician, so for those who don't know me, I'm an allergologist and clinical immunologist, and I mainly work as a clinical doctor at Vilnius University Hospital Santaros Klinikos, which is the second largest hospital in Lithuania, after Kaunas Klinikos. So, and my presentation will be regarding immunodeficiencies based mainly on the data of our hospital, our center, with some data from Kaunas Klinikos. So talking about immunodeficiencies, in Lithuania we have two centers for primary immunodeficiencies, in Vilnius and in Kaunas. And in Vilnius it was established in 2013, in Kaunas rather at the similar time. Our center in Vilnius deals, I would say, serve for the half of the Lithuania. We see those mostly patients from that part of Lithuania, and we are dealing with the primary immunodeficiencies and only in adults. Half a year ago, it was a split of our specialty, which was from the establishment in the 80s last century, together for children and for adults, and now, half a year, we already have different specialty, pediatrician allergologist, so they take that part of patients into their arms. So we don't have statistics regarding children here. So at our center, we can do quite a lot of things, detailed immunological testing, applying various techniques, and also, I would say, very good genetic testing possibilities, although human resources and money are always in short, as probably everywhere in the world. And we are also participating in the registry of the European Society for Immunodeficiencies since 2016. So our patients' data goes into the European registry. So what can we say about our patients? We have 81 adult patients with diagnosed and confirmed primary immunodeficiencies, roughly equally males and females. And median age of our patients is 41 years. So it was calculated the minimal prevalence of possible adults' primary immunodeficiencies in Lithuania, and it is 2.5 per 100,000 inhabitants. So when comparing with data from different European countries, you see it varies a lot, from 1.5 to 8.5, almost 9 patients per 100,000 of inhabitants. So, I mean, we are not very good, probably. There are some space for better diagnostics, but still we are not, very bad. And here I also would like to point out that when our center was established in 2013, so the number of registered patients, of new patients, really increased. So it shows that it's very good to have a specialized center, although you probably can think what it is for, but it's good to have people who are dedicated and who are collecting data in one place. These are diagnoses, the patients we have now on our registry. So it's predominantly patients with antibody deficiencies, 76% of all patients. Because it is, let's say, rather not so severe immunodeficiencies, it's frequently manifest in adult age, and also it is diagnosed very, let's say, relatively in a simple way. Then the second most biggest group is the complement deficiencies, and all these patients are C1 esterase inhibitor deficient patients who has hereditary angioedema. And other diseases, they fall in the smaller categories, and really we have 1 or 2 or 3 registered patients with these problems. So most of our patients are diagnosed already being an adult, so 90% diagnosed of primary immunodeficiency being an adult, but the mean age, but the lowest age when the patients were diagnosed was when the patient had X-linked agammaglobulinemia and he was 6 months of age. And the oldest one, 74 years of age, he was diagnosed to have hereditary angioedema at 74. All those symptoms started when the patient was 12 years old. So imagine she lived all her life suffering from the disease, not having diagnosis and proper treatment. This is an example, also the cases, number of the cases we have registered. So it's maybe not very what we can expect. So selective IgA deficiency, which usually goes asymptomatically, and usually it is diagnosed accidentally, let's say so. So it's the biggest part of the immunodeficiencies with the lack of antibodies, but also common variable immunodeficiency, isolated IgG subclasses deficiency, selective IgM deficiencies, and thymoma with immunodeficiency. We have several cases. As I told, C1 inhibitor deficiency is also quite well diagnosed, and as you can see, not so many other diseases we have. Genetic testing. We have really quite good facilities and possibilities to do. I would say on the European level, I mean, we don't differ from other countries, but genetic testing was performed only in a lower part of our patients. You may wonder why. It's because, mainly I would say because of the price of the waiting list and on the getting the results. And another part is of the interesting phenomenon which we observe in some patients where really we suspect that they have monogenic defect, like in hereditary angioedema. They refuse testing and also testing their children because maybe not knowing it's better. So that phenomenon, which is very hard to understand for me, especially when refusing testing children, but they say, well, they don't have symptoms yet. Maybe when they will have symptoms, we will test. So that's interesting phenomenon, why it happens. And we don't have a lot of mutations detected. I would say only few. And it's also a problem of the human resources, I would say. All this blood is biobanked, so it is possible from time to time to look through and to search for new genetic defects, but there is no so many doctors, genetics, who can do that. I mean, they have so many jobs to do, and that's why quite a lot of things are probably undiagnosed and cleared. And this is data from CONUS. They have around the same amount. So here in Lithuania, we would say we have around 200 patients with adults with primary immunodeficiencies. So they also, majority of their patients, they have selective IgA deficiency or common variable immunodeficiency, C1 esterase inhibitor deficiencies, and others are just a few cases. And now I would like to present you a clinical case, rather illustrative, like an average our adult patients with primary immunodeficiency and the way they have to go to the diagnosis. So when this lady presented to our clinic, she was 43 years old, and she came because she had a lot of symptoms and nobody knows what it is, what is disease she has. She had chronic diarrhea, weight loss, infertility, frequent bronchitis, and infections, acute salpingo-eryphoritis, and then peritonitis, for which she was operated on. She was hospitalized several times, and mainly because of the diarrhea, and from time to time it was very profound, so she really lost a lot of weight. She was investigated by a gastroenterologist several times. A lot of research was done, and also sometimes biopsy showed probably it is a Crohn's disease, probably it's ulcerative colitis, but it was all these diagnoses were inconclusive. So it looked like some familiar disease, but it looked a little bit different. So she even was treated with light immunosuppression, and it was partially effective, but not so much. And that's why doctors, gastroenterologists, they thought thought probably it is should be something else because disease is not so it doesn't go typical case. They performed rather specific investigation, protein electrophoresis, and looked that gamma globulin fraction is very low. So then she was referred to allergologist and clinical immunologist. At that time, when we performed testing, we found that she has no immunoglobulin A and she has no immunoglobulin G at all, or let's say very, very, very small amount, not detectable. And on flow cytometry, we found that there is some B lymphocytes, but not so many of these. So investigated other organ system. We done lung CT scan and we found bronchiectasis, which is very typical for chronic infections, long-standing infections, that there is some anatomy already, changes of the anatomy of the bronchi. And based on our findings and based on the criteria, which slightly differs between ACID and ICON, but she fulfilled criteria for common variable immunodeficiency, and she was started to be treated with first with intravenous immunoglobulin G substitution, and later when it became available with subcutaneous immunoglobulin therapy. And here is like a graph how these immunoglobulins she was able to achieve from 7 to 9 grams per liter, which is quite good. So it's the lower limit of the normal values. She has no IgA and IgM still. What changes in her life? Of course, bronchiectasis didn't disappear, so she will be with that problems all life. Gastrointestinal problems decreased. It was only 2 times with acute gastroenterocolitis, but in general, she had a decreased number of infections in her life. She was vaccinated against COVID, and she was able to produce some anti-COVID antibodies, and also she had that infection, but pneumonia was not so severe, so she fully recovered as outpatient. So she lives a normal life, but those complications was already developed, so she has them with her for the rest of her life. So in Lithuania, when we detect antibody deficiencies and we decide to treat, there is indication for the substitutions. We really have very good possibilities to do that. We can do intravenous immunoglobulin G substitution and also subcutaneous, which is very good for the patient. He or she can do it at home. They are taught how to do that, and they once a week or with new preparations only once a month they can do that infusion into subcutaneous tissues, and that's really very simple, and it's compensated 100%. And this is an example about the compensation possibilities. So subcutaneous, there are TLC, ICD-10 codes, so various immunodeficiencies when immunoglobulins are lacking, although also secondary immunodeficiencies where immunoglobulins are lacking can be treated by allergologists and clinical immunologists, and also by pediatrician allergologists as an outpatient. And when it comes to intravenous substitution, then it's a little bit difficult. Only common variable immunodeficiency can be treated with substitution intravenously and be compensated. Otherwise, in other indications, the hospital has to pay by itself from their own resources, and it's really then administration is not very happy to do that. So, and also those people with the primary immunodeficiencies, they have better access to specialists, to allergologists and clinical immunologists. As you might note, in Lithuania, for the specialized doctors, you have to have a referral from the family doctor, and it takes a lot of time. But people with primary immunodeficiencies can go directly to the allergologist twice a year, just prophylactically, without any specific referral, just for checkup. And for another immunodeficiency, for C1 esterase inhibitory defect, we also have very good access to medication here in Lithuania. For the acute attack, people can get human C1 esterase inhibitor concentrate or icatibant, which is bradykinin receptor antagonist. And recently we got a compensation for the lanadelumab monoclonal antibody against kallikrein. So it's a really very nice thing to have, but of course it took 3 years to get those drugs to be compensated, and it took so many efforts. We are a small country, there is not so many people. For instance, now only two persons in Lithuania are receiving lanadelumab. So, and it was, pharmaceutical companies are not interested in that. For the health ministry, they have so many things to do else. So it took really enormous efforts to get these drugs for compensating, on the compensating list. And that's why I'm saying it to you, because I feel proud that it's possible that if the simple doctors, practice doctors think that something is needed, it's possible to do, but it will take a lot of efforts to get it. So, and the message we are sending to our colleagues all the time, from time to time, so that primary immunodeficiencies can start at any age, and really when it starts in children, so in childhood, so it's really probably it is severe ones, yes, but in adults it's usually is neglected. Nobody just think that it could be like this. And of course everybody thinks about infections, that infections should be frequent, something should be unusual. Yes, that's true, but there are also manifestations. Those people are much more prone to get hematological malignancies, for instance lymphomas. Those people are much more prone to get pulmonary complications like bronchiectasis, and those people also are more tended to have autoimmune diseases. And we are asking doctors, colleagues, that before having patients with these diseases, and if the disease cause is somehow unusual, think about immunodeficiency. If you are planning for those diseases, start treatment which will be acting on B cells, B-cell depleting treatments, do immunoglobulins before, because in all patients this B-cell targeted treatment will reduce immunoglobulin production. But if you don't have immunodeficiency, so probably in a year or two everything will come back to normal levels. But if you have, probably you already had common variable, for instance, immunodeficiency before the disease was diagnosed, so that treatment probably will switch out your B cells forever. And then it means that you will need, it's nothing, no tragedy, you can substitute that, but you have to think about that possibility and test for that. And also, there are some signs of primary immunodeficiencies which are more prominent in adults, and we try to spread that knowledge. So it is not that when we are talking about increased number of infections, so how much it is. So according to European Society of Immunodeficiencies, 4 or more proven infection. It doesn't mean that the patient thinks that he had pneumonia. It should be proven with an X-ray, for instance. Recurring infections or infections which requires prolonged antibiotic treatment and probably several antibiotic courses. When there are bacterial infections, 2 or more, which are deep-seated, like osteomyelitis, meningitis, and so on. And also primary immunodeficiencies in families. So we are frequently asking about family history, because 20 maybe not, but 30, 40, 50 years ago, probably nobody searched for that infection, diseases, and unexplained death of infants or young adults without no trauma or whatever. So it could also pose that probably it was some disease which relates to immunodeficiency. And we have also some challenges, like probably everybody, but we are very trying to fight with these challenges. especially with the low awareness in other specialties about possibilities of these diseases. There is also challenges in diagnostics. There is no so many dedicated specialists like genetics, rheumatologists, or whatever. So recently, we just sent letters to other departments of our hospital asking maybe there would be some doctors who would be interested in these diseases. So we can have maybe gatherings, maybe we can send each other patients. Our Society of Allergologists and Clinical Immunologists would be able to pay for the conference attendances and so, but we got only few responses. So, I mean, everybody is so full, overbooked with work, so practicing doctors don't want to do something new. Of course, financial things. So, consultations and investigation cost. And there is just an example. I just tried to calculate how would it cost the full, it's a rough estimation, just only laboratory test for the investigations of the immunodeficiency, and only lab, it costs around 700 euros. So compensation for the consultation from the insurance, from the state insurance is 70 euro. So you see, it's a huge discrepancy. No administration is happy to have such doctors consulting and making, things, yes? And if we want to have a new test added to our panel, so it's always asking, well, who will pay for that? So you see, there is problems, and we are trying to overcome this. We are negotiating, trying to have a specialist of the which will health ministry will pay for that investigation if there is a suspicion of the immunodeficiency. We try to establish a network of specialists from different specialities. We try to educate also physicians at our center, allergologists and clinical immunologists, going to different congresses and also seeing other possibilities which are nowadays online. You can see a lot of things. We try to spread knowledge going to other societies, national conferences, although it's also not very easy to come into other specialties conference and to say something. And also we are working on diagnostic protocols, which we think it would be much easier and more clear for doctors when you have a protocol and you know what to expect, what to do, what to perform. Maybe it will also facilitate that diagnostic process. So thank you for your attention, and in my presentation I use data from our center and from the Dr. Kotryna Linauskienė and the young doctor resident Agnė Kuzminskytė, and also from my colleague from Kaunas, Dr. Edita Gasiūnienė, who is in charge of Primary Immunodeficiency Center in Kaunas Klinikos. Thank you very much.
Thank you very much for a very interesting presentation about immunodeficiency diseases in Lithuania. Any questions from the audience? So maybe during or maybe Professor Gedriminė would like to ask somebody, our guest from United States.
I'm very interested in this whole presentation because it was very interesting for me to know how you are identifying these patients.
Thank you for your question. So in Lithuania there are two places, in Vilnius University Hospital and at Kaunas University Hospitals. So these patients should be referred by family doctors or by other specialty doctors. And there are allergologists and clinical immunologists. It's not so many of us. In Vilnius we are 7, and in Kaunas plus minus also the same amount. So whatever doctor they will get in those centers, so they will be diagnosed, let's say so. Genetic testing cannot be done in other hospitals, only in those 2 hospitals. And once they are diagnosed, so they are captured in our hands forever. So they have our emails, our phones, so they can approach us whatever problem they have. And usually we are acting like their, let's say, somehow family doctors, yes. So they have different problems because they can develop also on substitution therapy, also they can develop lymphomas, chronic gastrointestinal disease. So then they are approaching us and we are organizing consultations with other departments and so on. But we ask those patients to be, attached to our center and to our doctors. Now it's around 100, so it's feasible to do.
Thank you. And Professor Peter, please.
Well, Laura, congratulations to what you achieved here. This is really fantastic. And I have, from the German side, an experience that we actually could well join forces with the rheumatologists. And this is now spreading over the country. Most of the departments of rheumatology are also taking care of clinical immunology patients. Would that be a possibility in Lithuania? This is my first question. The second is, we do encounter now, less in Germany, but in many other Western European countries, problems of having enough immunoglobulins for substitution. And apparently this has not yet reached Lithuania so far. What is your feeling about, let's say, establishing a demand management plan for immunoglobulins? We are about to do this in Germany. And how do you feel about collaborating with rheumatologists?
Thank you for your question. So rheumatologists were that specialty who didn't send any doctor to our team. Yes, but yes, that's a pity, but I can understand everybody is so overcrowded. Yeah. But we know Professor Klaus Warnatz from Freiburg, and we are going to attend that winter school, which will be going in Freiburg.
He's one of my pupils.
Yes, yes. So really, I mean, we didn't lose hope yet, so probably we will collaborate with rheumatologists. At least we still are sending patients to them, but it's so good to have somebody who is interested. Absolutely. I mean, reading that, and have deeper knowledge in that. And regarding shortage of immunoglobulins, yes, it comes from time to time. And you know, Lithuania is not a big market, and here are quite big restrictions for the drugs coming from the, when there is a shortage, it's not so easily you can get obtained from another country. So actually, if you see shortage, so just know that we already have felt that, because companies are sending to big markets, not to a small one. Yes. So.
Thank you. Now, just to mention that Klaus Warnatz, as Bodo Krimbacher, both are rheumatologists at the same time.
Yes, we know that. Yeah.
Yes. So, thank you. And now we will go to the last hour presentation. I would like to introduce young Dr. Goda Filipavičienė from Lithuanian University of Health Science Hospital. Today our conference is devoted practically to rare diseases, and in Lithuania is a lot of centers of rare diseases in both university hospitals. In our gastroenterology department of Kaunas Klinikos also we have a rare center for gastrointestinal and liver diseases, which is full member of European network of rare diseases. So one of the cases which diagnosed in our center, quite really rare disease and related with immunology, will be presented by Goda. Please.
Hello everyone. As Professor said, my name is Gona and I'm a resident doctor of gastroenterology. And today, along with Professor Kupčinskas, I'm going shortly present a clinical case of a patient with luteinized tecoma and sclerosing peritonitis. So, a 44-year-old woman presented to Lithuania University of Health Science Clinics because of unknown origin ascites without any other symptoms at that time. Talking about past medical history, patient was without any other diseases. The only complaint was that since April 2022, she noticed that she had increased volume of the abdomen and late irregular periods. So she decided to go to gynecologist in Klaipėda, and after the pelvic sonography was performed, we noticed that she had enlarged ovaries, and we decided to perform a bilateral salpingo ovarectomy. And after Klaipėda hospital pathologist examined ovaries, they diagnosed patient with ovaries fibroma, and she was discharged home. But after about 1 month, patient noticed that the volume of the abdomen increased again, and she came, as I said, to our Lithuania University of Health Science Clinics, and this is the point where examination started. So after diagnostic paracentesis was performed, ascites was inflammatory without any neoplastic or other changes. We examined our patient mostly of all possible causes of ascites, such as liver diseases, autoimmune diseases, TBC, and so on, but diagnosis was not detected. While we tried to figure out what caused ascites, patient condition get worsened. Anemia, malnutrition, cachexia developed, and ascites increased, so we decided to perform CT scan, and our radiologist suspected multiple metastases in patient's abdomen. So the next step was diagnostic laparoscopy, and omentum and peritoneum fragments were taken. Our pathologist examined it and found significant fibrosis with inflammation. And this is the point when we suspected that our patient might have a rare disease called sclerosing peritonitis. So we also performed PET-CT scan, and non-specific diffuse accumulation of VDG uptake in the stomach and peritoneum was found. Also in literature we see that these founds are often seen in patients with sclerosing peritonitis. Also, a large amount of fluid was found in patients' pericardium, pleura, and peritoneum cavities. And in this picture, we see how those red lightening areas are those VDG accumulations. So we finally have a diagnosis, sclerosing peritonitis, but the other task was to find what caused this disease. And our Professor Kupčinskas had an idea that it might be caused by ovarian stromal benign tumor, luteinized tecoma. So we gave our Kaunas Clinics pathologists to review the material from Klaipėda Hospital for ovaries, and they approved our suspicions that our patient has rare disease, luteinized tecoma, and sclerosing peritonitis. And in this picture, we see how ovaries look like if they are damaged by luteinized tecoma. In most of the cases, they are yellowish. So shortly about this disease, luteinized tecoma with sclerosing peritonitis is really rare disease. Less than 50 histopathologically characterized cases have been reported in literature till today. And as I said, this is an ovarian stromal benign tumor, but the pathogenesis of this syndrome remains still largely unknown. And in most of the cases, this LTCP occurs in young women with manifestation of bilateral ovarian masses, ascites, abdominal pain that most of the time are caused by bowel obstruction. Also, this disease can occur with estrogenic or androgenic manifestation. So to diagnose LTCP is really challenging because unspecific clinical presentation and low incidence. And the treatment that literature suggests is total hysterectomy with bilateral salpingo ovarectomy, also anti-estrogens, high dose of intravenous corticosteroids, and colchicine. And I think it's appropriate to note that this disease has a bad prognosis. Most of the patients develop intestinal obstruction, gastroparesis, fistulas, and LTCP are usually fatal, and high morbidity is indicated if multiple surgical procedures are done because of bowel obstruction. So how this disease looks like histologically, we see in upright corner how normal peritoneum have to look like, and down here we see our patient's material, so we see normal fat cells and not normal fibrosis with hyaline areas. Histology of ovaries, also in upright corner we see how normally ovaries look like. We see cellular stroma and some follicles, and down here we see our patient's histology material, so we see normal cellular stroma and not normal edemose stroma. And as I said, to diagnose this disease is really hard because we can say that even before pathologists examine ovaries, they had to suspect this disease, and you have to use inhibin staining because TECA cells are inhibin positive, and right here we see after inhibin staining was performed, we see those brown areas are TECA cells derivations. So finally we had the diagnosis, and now we have to figure out how to treat our patient. So surgical treatment was performed earlier in Klaipėda Hospital, so our task was medications, and as literature recommends, we gave a high dose of intravenous corticosteroids and antiestrogens, but unfortunately no clinical effect was found. Also, we gave a dose of colchicine, 2 grams, but even after a few doses, we saw the possible beginning of disseminated intravascular coagulation, so we had to stop this medication. And while we tried almost everything that literature suggests, our patient's general condition get worsened significantly. The clinic of intestinal obstruction developed after X-ray examination, contrast examination of a gastrointestinal tract. We saw that within 24 hours the contrast remained only in stomach and small intestines. Also we performed gastroduodenoscopy and we found severe gastroduodenostasis. So our patient was diagnosed with pseudo-obstructive syndrome. Nasojejunal tube was inserted. Patient was fed only via tube and parenterally. She also needed decompression probe. Therapeutic paracentesis was performed once a week, and unfortunately her physical condition got worsened significantly and her ECOG increased from 0 to 3. And also I would like to show how in sonography patient's bowel looked like. We see an extra layer of fibrosis. Sorry. Right here, everything is okay. I would like to show. This is the extra layer of fibrosis that all patients' bowel was covered. And this is why she had pseudo-obstructive syndrome symptoms. So, as I said, we tried everything that literature suggests, and our patient was in condition in fatal way, so we had to figure out what to do next. And because we know that interleukin-6 have been found in variety of chronic inflammatory disorders characterized by fibrosis, our professor had an idea to try to examine the level of interleukin-6 in our patient's plasma, and the result was 32. It was increased, and these finds led us to immunotherapy of tocilizumab. And because we know that tocilizumab has been shown to have a potent antifibrotic activity, we decided to give a dose of 8 milligrams per kilogram. And finally, we can say that even after first dose, patient condition gets truly better. And also before immunotherapy, we noticed that our patient has secondary immunodeficiency of immunoglobulin G. And we gave a high dose of intravenous immunoglobulin. The dose was 2 grams per kilogram. We think that this secondary immunodeficiency was caused by Tecoma-induced autoimmune disorder. The dose of 2 grams per kilogram we divided into 5 days. So how immunotherapy effectiveness looked like in ultrasound views. So this is here we see our patient's small intestine before tocilizumab, and this is the layer of fibrosis, and it was about 0.7, 0.6 centimeters. After first dose of tocilizumab, it increased to 0.4, and yesterday we perform ultrasound one more time, and the layer of fibrosis decreased even to 0.2. This is how it looked like in laboratory tests. So before tocilizumab, patient's CRP level was 110, and after we started the immunotherapy, it increased to the normal level. Also, albumin level increased from 80 to 36. Protein level from 44 to 58, and hemoglobin from 18 to 110. How immunotherapy effectiveness looked like clinically. So one more time, patient before we started to use tocilizumab was with the compression probe. Feeding was provided only via tube and parenterally. Paracentesis was performed once a week, and her ECOG score was 3. Even after first dose of tocilizumab, she didn't need a compression probe or paracentesis, but still was fed via tube and parenterally, and her ECOG was 2. After second dose, she still was fed via tube and parenterally, but with minimal amount of it, and she started to eat orally, and after third dose of tocilizumab, she ate it only orally, and her physical condition was mostly in the same position that it was before this disease occur. And happily we can say that now our plan is to discharge our patient home with treatment with tocilizumab every 2 weeks, and with replacement therapy of immunoglobulin G and tamoxifen. So for conclusion, I would like to say one more time that luteinized sarcoma with sclerosing peritonitis is an extremely rare syndrome. The treatment of this disease has not been standardized, and the clinical management is often challenging, and most of the cases in literature of these patients are fatal. And now we can say that LTCP can be associated with increased plasma levels of interleukin-6, and why we decided to present this case today, because this is the first case in the literature of successful treatment by tocilizumab in combination with tamoxifen and the replacement therapy of immunoglobulin G. So it's a big honor for me, and thank you for your attention.
Thanks you for very clear presentation of these rare diseases. Maybe any questions? Yes, please, Professor Peter.
Congratulations to this nice case report. Evidently, I will ask now, did you measure IgG4? Because sclerosing peritonitis can occur in this condition as well. And the next one is the immunoglobulin replacement therapy. What do you think was the role of this treatment in the success of your therapeutic strategy?
Maybe I could a little explain clearly. Of course, the immunoglobulin G4 testing is essential practice in patient if he has pancreatic disease, pancreatitis, or cholangitis, unclear origin, so it is very cheap and simple test in differential diagnosis. But in any unclear disease, of course, in our clinic practice, we test immunoglobulin G, and this case is absolutely normal at the beginning, and we think that the secondary immunodeficiency, which developed in the peak of disease when patients are practically non-eating low hemoglobin, severe ascites, and full gastroparesis, full gastroobstructions, tubes for gastric decompression once include due to, secondary due to malnutrition and of course to autoimmune disease. But now all immunoglobulin levels are normal, and we are not aware that it will be in future even replacement therapy, because in case immunoglobulin G would be normal, patients would be only on tocilizumab, and of course tamoxifen, who is anti-androgen, but it is mainly antifibrotic agent in this case. It is quite successful case, and I think our young colleague quite comprehensively explained and presented it. In case any other questions is absent, I would like, on behalf of our Department of Biology, Medicine and Geosciences, to continue discussion with cup of coffee in the next room. Thank you all for attention, especially thank you for our honorable guest here, and please go to discussions with coffee.